researchers at the Imperial College Centre for Psychedelic Research in London have been churning out breakthrough after breakthrough. Clinical director of the centre is Dr. David Erritzoe, senior lecturer and consultant psychiatrist at Imperial, whose neuroimaging work together with Dr. Carhart Harris and Professor David Nutt includes investigation of the mechanisms and therapeutic potential of MDMA, ketamine, and classic psychedelics. Here today to talk about psychedelic breakthroughs from Imperial College, please welcome Dr. David Erritzoe.
Thanks for the introduction. Thanks for being invited back. It's exciting. I was also here 2 years ago, and several of the speakers are back in business, so that's a pleasure. And what a powerhouse of the organizers 2 years ago, and again this time. It's an incredible effort and beautiful conference, so thank you for allowing me to be part of it. So this title about breakthroughs for Imperial, I did not come up with. I feel that the last several times that I've given talks, it has been some very grandiose kind of titles that somebody kindly did, because maybe I didn't send one, so just get your expectations a little bit down at least. And then to make it even worse, my first slide was also in Lowen's talk. We hadn't coordinated that. So where Lowen was focusing on the bullseye, which is basically the only approved licensed drug, which is the S-ketamine Spravato, Rick, who's sitting here, they were in kissing the bullseye last year, as you know, with the MDMA model, and we'll hear from him tomorrow more about what the status is now and what the plans are to get it in the red zone, hopefully in the near future. But as Lowen said, there's tons of trials with tons of drugs for tons of indications happening, and that's basically the current status, that it might take a few years more before the next ones are coming. It's probably going to be MDMA for PTSD and psilocybin for treatment-resistant depression. They are the most progressed, but you never know. Some might speed it up and get in there before in the red zone. So how do we study it? I mean, one of the typical way to do it in trials, and to refer back to Paul Stamets earlier, that these are the boring clinical trials with placebo and with clinical settings and so on, but that is what's needed in order to get it into that red zone if we want to develop it as these drugs as medicines. So one gold standard way of doing it is to randomize people in a couple of different arms, one with a control condition. That could be an inactive or an active placebo. It could be like in one of our trials where we actually had the comparison as another conventional treatment, SSRI treatment, for instance, that we then compared psilocybin to in a depression trial. So but that's not always used, and particularly early on when you test a new indication and do proof of concept trialing, you might go for an even simpler, a simpler design than this. And you can also come in with a really funny slide that Paul Stamets showed about the people in the placebo group, because you have that issue with the full doses of these drugs, that they are obviously impossible to proper placebo control anyway. So therefore sometimes we do simpler designs where we might put in the placebo into the same arm, so people might get a placebo and then later on the full dose, and that in a way reduces the number of participants to half, so it's a bit cheaper and simpler to do it that way. And because you have that issue with placebo and blinding anyway, this will do at least at some point early on in development. And an even simpler version is doing it completely without a placebo. And that we have done at Imperial. Sometimes our very first depression trial, now several years back, was an open label, single arm without a placebo. So that can also be done. Typically, that's the early part. What you then put in, you have if it's a depression study, you would have validated gold standard measures, scales, questionnaires of depression, clinician rated, patient rated, put in before and after. And that's typically your predefined primary outcome in these trials. You need to know exactly what you're measuring and what is the main thing and how you're going to analyze it, so you just don't invent that as you go along. You need to have predefined that. But there are some issues with that, and I think for the greater understanding of the value, potential value of these new paradigms with these new drugs, we need to maybe look a bit beyond these straightforward, classic, conventional measures of the conditions and go a bit beyond. So in a lot of our trials, we also put in imaging before and after, because we are focusing a lot and are trained in being very mechanistic and very brain imaging, and so are other groups around the world. So with the tools that we use, we can have molecular, very pharmacological, very precise measures where we can actually tap into the brain pharmacology, measure receptors, measure release of transmitters. That's very expensive, quite invasive brain imaging. And we can also use MRI, both structural and functional imaging, that we have used even more, and we have used EEG, and other people are using that. That's cheaper, simpler, and you heard Chris Timmerman earlier in his studies with on consciousness, DMT, and 5-MeO. It's these ones, and we have used those across a lot of the clinical studies as well that we have conducted at Imperial. And instead of showing you a lot, because it's a growing thing, so if I was going into too much of the brain data, it would take the whole talk, and it's not that it's not interesting, but you know, have to I curated myself here and said, okay, you can read that one from last year, an attempt to give an approximate overview of some of the imaging findings from the trials. But I thought wanted to speak about other things here, and one thing taps into what I was opening the door for just before. If you ask clinicians, psychiatrists such as myself, how to rank the importance of things to sort out for a patient suffering depression, not surprisingly, you will have clinicians ranking the top ones as the core symptoms of depression that are, in the first place, defined by, in a way, psychiatrists in an arbitrary way, somewhat arbitrary way anyway. But if you actually ask patients themselves, the people who live with depression or have been living with it, to rank the same things and what would they like to have changed, they are actually more wanting to enrich their life with joy and meaning of life and satisfaction and so on, rather than just getting rid of the core symptoms of depression. So there's a bit of a discrepancy between what we think we want to do for the patient and what the patients themselves actually want. And that brings me to a sort of concept that I think is quite a common denominator in a lot of mental health conditions, being stuck, being entrapped, being in an inverted space that is difficult to break out of in whatever non-psychotic mental illness we are speaking about. And here I will list a range of different psychological factors, things we can assess and measure and assess that speaks to the stuckness. Some of them are more related to some conditions than others, and as you might notice, none of these concepts here are specifically the core things that we typically are measuring in an addiction trial or in a depression trial, anxiety trial. Those would be the normal standard clinical measures of those core symptoms of the conditions. But these are sitting around it and are deeply important for patients in that stuckness that they are experiencing across trials. You have both behavioral, emotional, psychological kinds of stuckness, and they are all represented in different aspects here. Something like experiential avoidance, being so trapped in a state that is where you are fearful and unable to fully approach and work with the core of what you're actually suffering from because it's too painful, too difficult, is a very common feature across all mental illness. Also pre-contemplation in addiction, in eating disorder, this sort of state where you're not ready for change. You're actually not fully ready to undergo the treatment. Whether it's rumination, being stuck in negative thought loops and so on, all these relate to stuckness, behavioral or on a more emotional level. So, and some of them, as mentioned, relate more to some conditions than others, and some more broadly across all. And this is sort of my way in to see and try to present some views of why this novel modality, not novel, they're not novel, we also heard about that today, they're really not novel, but in terms of being introduced in Western medicine, they are. And one of the reasons is that they seem to have quite profound effects. Some of the things we are still testing in trials, both at Imperial and other places, in different experiments, but a lot of it we already have tested, and as you can see, a lot of these stuckness features are changed and reduced. So basically, it seems to make people less stuck. If you look at the cloud here to the left, they speak into a flattening of affect, a blunting, which is actually what a lot of patients on SSRIs are complaining of. And if anything, it looks like the psychedelics have changes that goes in the opposite direction. I think, so it's not just about the efficacy on the core measure of depression. You need to think about these treatments broader and what are additional benefits that are worth taking into consideration. So that's why I chose to focus a bit more of that in this talk and have these things listed here. So basically, now we stay with the same conditions as before, but in order not just to go, but also show something about the core features, we have data coming out actually from an OCD study, from anorexia nervosa or in chronic pain. So I'm not going to show them also in the interest of time, but the short message is that they look promising for the clinical outcomes, and they also tap into some of the measures that you saw on the previous slide. So broadly, looking promising also in these trials that are all being written up. And this one specifically on addiction, instead of showing data, again, the story is it looks promising, and we are launching new trials. I have a couple of slides on that in a bit. And then to mood disorder, or specifically to depression, we have tried very recently to create an overview that I know there also was a talk, I think yesterday, and a poster. This is even a bit more, with even more data in. This is from data where it's within. So you remember I showed you the different ways we can design the trials. If you have within subject, meaning you don't necessarily have a placebo control or control condition to compare to, you have the patient before a psychedelic intervention and after, and then you can calculate effect sizes. And these effect sizes are big, and this is the time scale. So you can see that even at the long-term follow-up time points across these trials, the effect sizes are high. So they are beyond, this one is 0.08, that is almost a large effect size. So they are very large in this within subject effect size view. Here we have taken the ones between, so this is where we take into account control conditions, placebo, or whatever they are compared to in these trials. So there people have been randomized, and that's a bit more gold standard way of testing, as I mentioned before. And we have, for completeness, put in here meta-analysis for SSRIs, and you can see that the effect sizes overall look better so far for the classic psychedelics, and you have DMT, psilocybin. The DMT trial I'm particularly interested in. I was part of running that trial, Chris Timmerman as well, together with Small Pharma, and basically you can see that's a 20-minute experience, so it's quite interesting that a short psychedelic after intravenous DMT in a depression trial look a bit similar to what we see with a 4 or 5 hour psilocybin session, so that looks very promising. You can also see here, this is the 6 months follow-up from that trial over here that also is looking good. And then you have the ketamine data. This is single administration. This is the more conventional repeated dose with ketamine, and it's quite directly compared to typically single dose of psilocybin. In terms of how is this a very different paradigm? The subjective experience, we heard a bit about it. Lowen also alluded to it. That there's something interesting. This is from not only our first depression trial, but kind of the first depression trial in the modern era. The last 50 years we did it like 8 years ago. What we could see here was that the people who responded best, who had a proper treatment response for their depression treatment in this trial with psilocybin single dose, the ones that responded best were the ones who had more of a peak experience, mystical type of psychological peak experience. And that, in a way, is seen widely across all these studies, no matter what indication. And it is also, when people bother to look at it for ketamine, seems also to be coming out for ketamine. So there is something about an association between the profoundness, the depth, the strength of the altered state of consciousness, the peak experience, and the clinical effects. So that, I think most of the people in this room probably already know that. We are seeing the same thing in new trials that are not necessarily out yet. But what about the million-dollar question is this a causal relationship or is it an association? So you can see from what Lowen was showing before, in the ketamine world, a lot of it speaks it down as a side effect. It's really not an important part of the way that they consider the model. It's a very biological, where it's about all the biological effects on the brain rather than the actual experience. So could it just be a side phenomena? Who knows? And it's very difficult to test. One study that came from Chris and the people in the lab that works with DMT, and Leo Roseman and Chris, they looked at the data, and because we had some people, healthy people, who had been given DMT, some of them had been interrupted. Every minute they got interrupted. Some had not been interrupted. So if you interrupt, then you have more an interventional testing of the subjective experience. And the people who were interrupted, not surprisingly, had less of a mystical type experience and also less improvement in well-being in these healthy. So that is a more sort of, it's not perfectly designed for it, but it's a stronger indication that there might be something causal about the experience. Then you can look to microdosing, because let's say that the experience really is absolutely instrumental, then why would microdosing work? Because you don't have much of a subjective experience. You don't have a peak experience in microdosing. It's sort of sort of sitting around the perceptual ability to perceive the experience, but it's not a peak experience with microdosing. So if microdosing really, really works, as well as full doses, it would kind of speak against that this subjective experience is absolutely necessary for psychedelics, right? So we are coming out, Orla Malin, who's also in a panel tomorrow. So we are doing this is not the final version, by the way, and we are soon coming out with this Christmas tree sort of attempt to do a full overview of all microdosing data. What is basically the short version of the story with this is that there's a lot of data supporting the effects of microdosing, but as soon as you start trying to placebo control it, it seems to diminish quite dramatically. So there, in data from our center and so on, we see that a lot seem to be driven by expectation and therefore placebo for microdosing. So that means, and I'm not saying microdosing doesn't work, I'm just saying that it's not convincing yet that it works significantly beyond placebo at this point. But there are trials, both Paul Stamets and his team, there are people in Australia and New Zealand that are doing nicely designed trials. That will be important to see. We're also doing a new trial ourselves. So jury is out, but it doesn't look particularly promising. So that, in a way, doesn't rule out that the experience is important at this point. If you really want to study it, you could put people under sedation or during sleep, or you could study non-psychedelic psychedelics that are being developed in different places. If they work as well, a lot of us doubt it, but we'll see. We'll also be curious whether they actually even can translate from the animal work into humans, and not when you give sufficient doses, whether it still won't be given a psychedelic experience. But that line of work will obviously be important to the question of how essential the experience of these drugs are. Now I can't seem to change the slide. Can you do it, maybe? And this is just because I showed that Christmas tree. Then I just put in an extra slide about microdosing. This is just an encouragement to use, if people want to do microdosing in naturalistic setting, survey-based. I'm not saying they have to, but I'm suggesting maybe consider using the method that we developed for self-blinding, instead of just collecting thousands of anecdotes that are going to show the same thing, that microdosing is great. Let's try to put in the placebo. We have the privilege scientifically to actually try and placebo control it when we speak about microdosing. So you can use that method, or we have an even more updated version that we're using in this study. And if people are going to microdose and want to help out with science, they're welcome to sign up for our next version here of our microdosing work. Now we saw that the peak experience seemed to be at least correlated with or associated with it. Whether it's causal or not, we're not sure. But therefore, it means that we're also interested in what can predict it. Can we actually predict anything? And what we know now across the therapeutic alliance, you also saw previous today, Communitas, low level, a low setting of your serotonin 2A receptor in a very small study, it needs to be replicated. High baseline openness. Openness is being pushed even to a higher degree after the experience, but at baseline, if you're high on openness to experience, one of the big 5 personality traits, that predicts more likely to have more of a peak experience. If you score high on the abilities to surrender, score high on ACE, that's adverse childhood event. So that's basically having a history of some degree of childhood trauma, seems to be a positive predictor of a peak experience. Then you have also what seems to be predicting a challenging experience, younger age, neuroticism, personality disorder, self-reported diagnosis of personality disorder. We are publishing that soon, and also a state of pre-contemplation. And then the really important ones, dose, not surprising, not particularly surprising. If this is pharmacology, which it is, then there should be a relationship with dose, and there is. That you are more likely to get either with a very high dose. Trait absorption is a very interesting one, and there are colleagues that actually are starting using them also for ketamine to actually clinically assess whether this is likely to actually have any effect clinically. That people are very low on absorption don't seem to respond that much to a psychedelic. Other things that predict negative experience. So here we did interviews with people who have had negative experience from psychedelics more than 3 days after they actually had the psychedelics. And again, some of the things reappear here, a bit overlapping with what also causes a challenging experience. In terms of how they differ from conventional psychiatry is that we have a combination of pharmacology and talking therapy. But how important is the therapy? You know that there's a movement in the industry to reduce the talking therapy element because they need to get it through the regulatory system, and they cannot approve or regulate talking therapies. So therefore, it's quite important to have an idea how important actually is the therapy. And that's not that easy to study, but we have some indications from ketamine showing what we, in a way, hope and assume that it does have an effect. It does seem to make it more efficient for ketamine if you combine it with talking therapy. The best, I think, study so far is an alcohol use disorder done in the UK by Celia Morgan's team, where they separate this exact way that you would hope and expect, that the real drug with the real therapy is stronger than a placebo with a sort of psychoeducation version, and so forth. So the therapy is adding to the model. And there are other data from Kyle Greenway and others that are coming out, and also from Pedro Rodriguez in Portugal, that seem to be supporting the same thing. And the duration is extended if you add in psychotherapy. So we are doing different things in new trials at Imperial. One of them is a ketamine pilot, where we will be basically doing it directly with the talking therapy services. So we are linking it in. We are doing training before the pilot together, and we are doing supervision of the teams together. So here people will be under the care of talking therapy service and getting weekly therapy while we come in with the ketamine over 5 weeks. So that is, and the reason why it's interesting, although it's a small pilot and it hasn't been done yet, is that it's within the public health system. This is within the NHS. So for UK people, I think it's a bit exciting that we have been able to and allowed by the NHS Trust to actually do this in the model that Lowen, Kyle Greenway, other people that work with ketamine in the less biological and more talking therapy enriched model are doing. So basically, that is one of our things that we are, in a way, playing with, hoping for scalability of these models. Then we have received funding to do gambling with psilocybin, a trial. And here, we are again doing something we haven't done before. So we are taking the dyad that are in the room and doing the prep, dosing, integration. We are having one of the dyads coming from the National Gambling Clinic. So a therapist who's not used to psychedelics, who will follow the patient through their pathway into the trial and back into their line of therapy. So we are replacing one staff by having them as the assistant guide, and they're basically just following the patient through and back into their pathway. So we are trying to integrate the care models together with existing NHS service, also in this trial, but in a different way. And then the last example is an opiate use disorder, so heroin addiction. We heard earlier about ibogaine, but we are testing psilocybin therapy for opiate use disorder, people with heroin addiction, and there are people doing it with fentanyl in the US that we are speaking close to, so we are coordinating. Orla Mellon, who's here at the conference, might speak a bit more about it tomorrow in the panel. So here we are again doing something we haven't done, so because there's a strong tradition in addiction services in the UK, but also outside of the UK, there's much more involvement, more peer support in addiction than you see in most of other mental health. So we are trying to use that by having people with lived experience who are therapeutically minded, have some training to be the second guide in that model. And that is basically it. Thank you.